My name is Gary Christian and I'm the President of Drug Free Australia. The title of this presentation, The Proven Success of Drug Prevention, is on your screen. And this presentation replicates the lunchtime session at Drug Free Australia's mini drug summit, which was on October 23, 2024. And you'd have to ask the question, why was there a mini drug summit? What does that mean? Well, as you can see on the screen, the New South Wales Premier had announced that there was going to be a drug summit, and that turns out that it will be in Sydney mainly on December 4 and 5. And Australia's main drug prevention organisations were not invited. And here you can see that on the screen, we have an email which is dated a full 5 months before the summit. And a number of other organisations went along and asked for the same privilege to be represented, but alas, we seem not to be welcome. And so we ran our own mini drug summit at Parliament House. All of the cited evidence that you're going to see within this presentation can be found by accessing this 63-page document. And it is full of information and it is full of hyperlinks which go to each data source. And if you just follow the instructions on the screen, you will be able to find it on Drug Free Australia's website. And there is the table of contents. It is a comprehensive analysis of harm reduction's failure in Australia. So it goes into a lot more than what we will cover here. We need to start with Australian attitudes to drugs. And very important, this is the question that we should be asking. Do Australians want less drug use or do they want more drug use? And I'm just going to round off some of these figures in descending order. But if you look at this table here, which comes from the 2023 survey, household survey, about 25,000 Australians, and you'll see that Australians do not give their personal approval to the regular use of heroin. That's the one that is up at the highest at 99%. 99% do not give the approval, nor do 99%, again I'm rounding, 99% do not give their approval to the use of ice and speed. For cocaine, it's 97% are not happy with that, and 95% for the use of ecstasy, 77% who do not give their personal approval to the recreational use of cannabis. And this is a really important question to be asking. Do Australians want less drug use or more? Obviously, if they don't approve of drug use, they don't want more. And that needs to temper all of the discussion that we have ahead of us. Now, Australia initiated harm reduction as an approach under the name of harm minimisation back in 1985. What you see on your screen over here is The Guardian. That is a news site, and it's an article by Alex Wodak, the person who introduced harm reduction to Australia back at that date. And he says within that article, when Australia adopted harm minimisation in 1985, both the term and the concept were novel in other countries and in the UN system. And he goes on to point out that most of these countries have adopted harm reduction in some shape or form. So what is harm reduction? We just need to go to a definition, and this definition comes from the International Harm Reduction Association. It's an old definition which they have replaced, but this is the original one, and it says down here, the defining features are the focus on the prevention of harm rather than on the prevention of drug use itself. And the focus is on people who continue to use drugs. Now, notice the intention shift, a focus away from the harms which are caused by drugs to other people by the drug user, which was where the 1912 conventions against illicit drug use sat. That was their main focus. Drugs were harming too many people. But it focused back then on the whole constellation of people around each drug user. And that changed in 1985 to a different focus, which was on the user themselves. Now, this whole constellation of people around each user includes the drug user's partner, and often their children, most often well, always their children, pretty much, if it is a highly addictive drug. The grandparents of those children. There are tens of thousands of grandparents who are looking after their grandchildren because their son or daughter is addicted to a drug and no longer does a decent role in looking after the kids. There are also siblings, there are friends, there are workmates, there are other road users, obviously. All of these can be endangered, workmates, other road users, and of course there is the general community. And so we need to ask the question, do harm reductionists believe that drug use actually does present unacceptable harms? Again, that's what they said in 1912, unacceptable harms to the community. And what they do is they say, oh, yes, we accept that there are unacceptable harms, but they are really unacceptable harms to the drug user. And so that's where our focus is going to be. But at the same time, they do admit that they are unacceptable because it's called harm reduction. We wouldn't reduce the harms of these drugs if they weren't hurting anybody. It's in the name, in the nomenclature. And so harm reduction pretends that drugs harm just the user and that the job of everyone else is to find the money to keep those people safe. So what could possibly go wrong? Well, here it is. This is what went wrong. So harm reduction became associated with Australia becoming the world leader in illicit drug use by 1998. Within a 13-year period, amphetamine use had increased by 500%, cannabis 300%, cocaine 400%, ecstasy 750%, heroin increased 300%. If you don't believe those statistics, they're right there on the screen in front of you. And they come from the National Drug Strategy Household Surveys from 1988 through to 1998. It's all there. By 1998, Australia had the highest drug use in the developed world. And there was a quadrupling of opiate-related deaths at the same time. Let's just go first to this graph here. Here is Australia sitting well above every other country, and followed closely by, of all countries, New Zealand, who had followed in our footsteps in 1987, 2 years later, by adopting needle exchange programs, as they used to call them back then. But notice that the US, which is number 5 in the world, it's only half the drug use of Australia and roughly half that of New Zealand. So the harm reduction countries that initiated this approach had done extremely poorly in terms of drug use. We had the highest use in the world. That was associated at the same time with a steepling drug use. This is going up. So back in 1984, the figure was close to that figure there, 240. And by 1999, it was up to 1,116 deaths. And what we see is that whenever harm reduction is ascendant, it's given priority over drug prevention and over rehabilitation. At those times, over those years, this was 13 years that we're looking at here, drug deaths and drug harms went through the roof. In 1998, a new federal government that had come to power in 1996 responded to calls by the media who were pointing to the massive number of overdose deaths within Australia. They instituted a new drug policy called Tough on Drugs, and that started in 1998 and went through a 9-year period after that. It put a lot of money, quadrupled the drug policy budget, put a lot of money into drug prevention and rehabilitation, as well as interdiction, which is stopping drugs at the borders or before they get to the borders of Australia. And you can see the success of what happened there. There are the real numbers of opiate deaths that plummeted 67% by 2001 and then maintained their way through to 2007. And so it was an unmitigated success. In 2007, a new incoming government, a different party, decided that they would scrap tough on drugs and reinstate a priority for harm reduction. And you can see what happened to drug use. Here is opiate use. Well, this is not use, this is deaths. Opiate deaths starting to skyrocket, as well as every other kind of drug. Every drug, even illicit alcohol deaths went up markedly during the next decade. Especially on this graph. And you can see with the figures up above that the minimum increase was a 210% increase and a maximum increase of around 590%. And so it seems that harm reduction was a mechanism which was able to lift all boats. We could say it's the tide that lifts all boats. Now, we can say, what about confounders? There could be all sorts of reasons for this other than drug policy. There could be a change in supply of these certain drugs. The only problem is changes in supply are only going to affect one of the drug types that you see on your screen at a time. A second confounder might be is that there could be a change in mortality definitions. But then the trend lines, as you see here, are in lockstep before you get the reductions of tough on drugs. And then they all go up. It's got nothing to do with definitions. It has got everything to do with drug policy. There are no viable other confounders that we can find. And so we have to ask the question, what are the likely mechanisms by which harm reduction so substantially increases mortality, deaths, and harm for drug users out in the community? So let's start with one that is highly evidenced and easy to understand, and that is pill testing. Now, there are no mysteries about what causes pill deaths in Australia. So this study that you see on your screen looked at 392 deaths from MDMA, which happened between the mid-2000 and mid-2018. So an 18-year period, 392 deaths. Now, in that period of time, there were 3 or 4 deaths from another drug, but all the pill deaths were from ecstasy, MDMA-related deaths. And the other deaths were N-bomb-E deaths, and there was some on the Gold Coast around the 2016, 2017 period. And the difference is that the people who were taking those drugs knew exactly the risk that they were taking with N-bomb-E. Here with ecstasy, it's quite different. And so here is what the science tells us. It says out of those 392 deaths, 14% died because of an adverse reaction to MDMA, the active psychoactive ingredient within ecstasy pills. Now, this was the very thing that killed Anna Wood, the first death from ecstasy within Australia. She took a pill, it was from the same batch, 3 or 4 of her friends also bought from that batch. They lived, she didn't. She had an adverse reaction to MDMA. And you've got to ask the question, is pill testing going to save lives of those who have these adverse reactions? Do they do a blood test to find out who is going to have an adverse reaction? The answer is no, we don't even know what to look for. And so pill testing is useless for that 14%. 48% died from reactions due to a synergy between different kinds of drugs. So when you've got ecstasy being used with alcohol or with cocaine or with ice, speed, this is co-using your pills with other drugs which are available out there on the market. 48% die from that. Now, does pill testing do a blood test to see whether a person has got alcohol or cocaine in their bloodstream at the time that they're going to take the pill? The answer is no. So it is useless for that. And somebody might say, oh, well, they can talk to the person while they're doing the pill testing, and they can tell them to beware of taking it with other drugs. Well, that can be done by any other communication mechanism. We don't need pill testing to get that message across. 29% of MDMA deaths are from accidents, mostly car accidents, while they are intoxicated on the substance. And again, you've got to ask, does pill testing do anything about that huge number? Well, of course not. It doesn't have a blood test and doesn't know how to test for accident proneness. There is no such test. And so pill testing is useless for the real causes of deaths within Australia. Now, less than 1%, it was just 3 deaths out of 392 came from bad batches of drugs. And it was just one bad batch in January 2017 in Melbourne. And there were 3 deaths, as I said. And it's really interesting that toxicologists have told us that the pill testing equipment back at that date would not have been capable of picking up the 3 drugs in that bad batch, which were N-bomb-E and 4-FA, along with MDMA. It would have been incapable. And so pill testing in all cases across that period of time would have done nothing to stop any deaths within Australia. Now, when we come to Pill Testing Australia doing its trials within Canberra in 2018 and 2019, it's like every other testing site, pill testing site throughout the world, treats MDMA as if it doesn't cause deaths, as if it is basically safe or benign. And it's interesting, this comes out of the 2018 evaluation. They give a red card when they test a pill and they find a substance in there that they believe will increase harm, multiply overdoses or death. Then they will give a red card to that substance. Now, we've just seen that ecstasy causes masses of deaths within Australia. 400 deaths is no small thing over an 18-year period. And yet what do? They give it a white card, this one up here, because the patron says, oh, I think I've got an ecstasy pill, and they find MDMA as the only psychoactive substance. They give it a white card, they green light it, they give it a pass and say, go on your way and enjoy your time. Now, ecstasy should be getting the red card. In 2019, they found 7 pills with N-ethylpentylone in there. And what that tells us is that around Canberra in 2019, there must have been a batch. Now, batches of pills would regularly be around 200 pills. There must have been a batch going around in Canberra. Nobody was dying from it. But of course, people were dying from ecstasy. And they gave this one the red card, but they gave ecstasy, the killer, the white card. Now, what sense is there in that? And think about that. If we want to know the reason that drug deaths in Australia are increasing under harm reduction, here is exactly the reason why. It encourages more people to take a drug which is deadly, and that is not helping at all. Now, in 2019, Pill Testing Australia changed their narrative away from contaminants and adulterants being responsible for all the deaths in Australia, which, as we just saw, wasn't true. There are only 3 deaths from that. And they now said that it was overdoses from unknown purity of MDMA, the psychoactive element in the ecstasy pills, that was killing everyone. And the fact is that this is outright misinformation, maybe disinformation. So even the best of the harm reduction outfits in the world admit that ecstasy overdoses are very rare. And so you look at this one over here. This is from the Drug Policy Alliance. This one is from DanceSafe. The Drug Policy Alliance, for those that don't know, is George Soros's harm reduction flagship. He's the one who funds most of the harm reduction around the world. And DanceSafe is also a very prominent US harm reduction service. And these are both happy to tell the truth. So here's DanceSafe over here. MDMA-related deaths, stop calling them overdoses. They're being truthful about it. Got nothing to do with purity. It's not got anything to do with overdoses. And here's the Drug Policy Alliance, that flagship for George Soros. Overdoses, it says, are extremely rare, and are also usually linked to dehydration or mixing drugs rather than as a direct result of using ecstasy. And so they can be honest about it, but not Pill Testing Australia. Why won't they tell the public the truth? And that's because they've got the media in their pocket, and the media plays along with this outright misinformation, disinformation. Here is a study from South Australia. It was done quite some years back. But what they did was they took 45 ecstasy users, I think it was about 45, and they took them and they measured the MDMA in each pill that they were using. And they took a sample and they measured how much was in each pill in milligrams. And so here is a pill here that was 25 milligrams. This one has 105 milligrams of MDMA in it. This one up around the 225 mark. Okay, so that's how it's measured there. Then they checked how many milligrams, micrograms, we better get that right, micrograms of MDMA were in the blood of each of these users. And look at the difference. Here is a user with 105 milligrams in his or her pill, and yet the blood level is only around the 120 mark of micrograms in the blood. Here is another user who's around the 115, maybe the 120 mark of milligrams in the pill, and yet in the blood, 1,050 micrograms in the blood. And so it tells you that purity has very little to do with anything. It's got a lot to do with how MDMA metabolizes in the body. And it's really interesting that 50% of those 392 deaths, see that shaded area there, of those 392 deaths, 50% of them had blood levels of MDMA which were below 450 micrograms. That's where half of them died with those blood levels. The other half died of those ones. Again, it has absolutely nothing to do with purity. And this is a little lie that they've been telling for years. They did the same with heroin. They told us that people were dying of heroin overdose all the time because there was concrete dust in the heroin that was mixed in by the criminals. This was never true. There were hardly any deaths within Australia that were from anything to do with the unknown purity of heroin or other contaminants in the drug. Same story, it's their playbook. And there is very good evidence that most overdoses from heroin happen because it is co-used with alcohol and other drugs, particularly benzodiazepines. And so what we're getting from pill testing in Australia is a narrative which is totally untrue, which encourages Australians to use more ecstasy because they make out that it's safe. And of course, we're going to have more deaths within Australia as a result of this harm reduction measure. Let's go to injecting rooms. Now, what you see before you is the world's only review that uses rigorous science to evaluate injecting rooms. There are a whole lot of reviews that have been done in medical journals, but they were all on substandard studies that were not rigorously scientific or quasi-experimental designs. But this one found two studies that showed success for injecting rooms that were quasi-experimental designs and measured up as rigorous science. And let's have a look at the first one of those. This one was from Lancet in April of 2011. Now, it's interesting that this study came out a week or two before the Canadian Supreme Court stepped in to stop the Canadian government from closing Insight down from lack of effectiveness and effectively being a waste of money. And so the study came up, the Canadian Supreme Court ruled in favour of Insight as a result of this study. And the claim that was in the Lancet study was that Insight, their injecting room in Vancouver, which opened September 21 of 2003, had reduced opiate overdose deaths by 9%. Now, interestingly enough, I had seen 6 months before this study came out, I had seen the British Columbia's coroner stats, which are on the screen right in front of you there. And I'd seen them at that time and gone through them, and I had noted that overdose deaths had actually gone up since the injecting room opened. So here are the stats. They're too small for you to see over here. But I've blown them up here, and you can actually see what was happening. You can see that in 2002, 49 deaths, and by 2004, the year after the injecting room opened, deaths are up to 67, and then they stayed up. And here is the graph that has been made from these figures here. The blue line are these overdose deaths. within Vancouver. This is British Columbia, the whole of the state. And then you have the downtown east side, which is the area immediately around the injecting room, where you could also see that there were increases in deaths as well. Now, how did they achieve this 9% decrease, so-called decrease, in drug overdose deaths in Vancouver? You can see what they've done. Back in 1998, drug overdose deaths actually peaked in Vancouver and in British Columbia. And at that time, a heroin drought, very similar to ours in Australia, we're not particularly sure exactly whether it was the same cause as for Australia, but there was a heroin drought in Canada. It just so happens that the researchers for this study have a whole paper on that heroin drought and the effect it had on drug use in Canada. So they knew all about this. And so drug overdose deaths started to go down markedly and bottomed out by 2002. And then you can see they start going up in Vancouver up after that date. And here is where the injecting room was opened in 2003. So what they've done is they've aggregated all of the numbers for a 2.5-year period back here, and they've gone against an aggregated number of overdose deaths over here, and they've said, oh, lo and behold, 9% decrease in deaths. Now, what they didn't do was break out the figures like the coroner report had, and they didn't do a graph like this where you could see that what they were saying was absolutely false. So this study, the first of 2 studies by Rand Corporation, by which it has recommended to the US government that they open injecting rooms in the US, this study has actually been based on something which is nothing less than a fraud. If it's not a fraud, it is inept researchers who don't know what they're talking about. That's the first of the 2 studies. Now, the second one is from the Sydney injecting room. And this was all to do with reductions in ambulance call-outs for overdose, for heroin overdose. And the interesting thing about this study, it was done in 2007, properly published in 2010, where they gave all of the data that they hadn't given in 2007. But what you see is in the media in 2007, what they told the public was this. They said the injecting room had reduced ambulance overdose call-outs by 80%. It was a great headline. So what was the reality? Well, there was a heroin drought that intervened in Australia, just like in Canada, but ours happened in the year 2000. It was around October, November, December of 2000. This injecting room opened in May of 2001. And so what you would expect is that overdose call-outs would go down for ambulance everywhere within Australia, and they did. In New South Wales, you can see over here 61% reductions in overdose call-outs because a heroin drought had intervened 6 months before the injecting room opened. However, King's Cross did actually do better. It had greater reductions, and there is the margin of reductions. It's 19% better than the 61% figure for the whole of New South Wales. And so, of course, this study said, oh, it's the injecting room that is responsible for all of these reductions in overdose. It's a real success. And obviously, the Rand Corporation accepted their argument. What the Rand Corporation didn't do was check the data within this particular analysis. And we've got to say, why is it that this figure here, this is neighbouring Darlinghurst. Now, Darlinghurst is about 200 metres, the border between King's Cross and Darlinghurst, about 200 metres from the injecting room. And it's underperforming. It hasn't got the reductions that even New South Wales has. And what you can see is that it seems as if the overdoses, the ambulance call-outs for King's Cross are somehow now going to Darlinghurst. Why would that be? Why would overdoses be going to neighbouring Darlinghurst? And the reason is very, very clear. So it just so happens that sniffer dog policing was introduced, and you can see it in New South Wales Parliamentary Hansard, where they voted this 1 month after the injecting room opened. And sniffer dogs were only allowed to go in the King's Cross precinct. They weren't allowed to go over the border except by special permission into Darlinghurst. And so their beat was within the King's Cross area. What caused the reductions in ambulance call-outs? It was the sniffer dog policing. All of the overdoses went to where the drug dealers went. Once they were scared across the border into Darlinghurst, that's where they had to go. And that's what happens with drug users. They're hanging out for their hit of heroin. They go and find the drug dealer, and as soon as they've been able to get their heroin and buy it, they go immediately and shoot up. And so all of the ambulance overdoses were happening where the dealers had gone as the result of policing. Now, how can we be absolutely sure of that? It's because of this figure here. At night, when the injecting room was closed, we had a far bigger reduction, a 29% reduction in overdose call-outs as against the rest of New South Wales. Darlinghurst, same phenomenon. People are going across the border into Darlinghurst, and it is underperforming in terms of the reductions that should have happened. It should have been 42% for Darlinghurst, but it's only 26% reductions because that's where everybody are having their overdoses. Now, it was the policing. It was the policing. Now, the things that we need to know about injecting rooms and why they are increasing deaths is this. Overdoses within Sydney's injecting room were in 2014 63 times higher. In 2010 was 63 times higher than otherwise recorded rates. Now, how do we know what otherwise recorded rates are? When injecting room clients went to the injecting room for the first time, they had to fill out a registration form and asked, how many overdoses have you had in your injecting career? The average was 3 for 45% of the clients. All the rest hadn't had an overdose. But 3 overdoses. Over what length of career? They were asked how long they'd been using heroin. The average was 12 years. You can work out an overdose rate from that, how many injections there are for each overdose, and you can work out a rate of deaths and so on. And so it is quite simple to work out overdose rates for people before they went into the room and the rates that are in the room, because that is recorded in the evaluation. In Victoria, the Melbourne injecting room had overdose rates that were 102 times higher than those rates. This is staggeringly higher than street rates. And you've got to ask the question, why is it that they are able to have all of these overdoses in the room? Now, we know from talking to ex-clients it is due to experimentation with bigger doses of heroin and using polydrug use with benzos and seeing how big a hit they can get, right? So this is why there are so many overdoses. But what does this actually mean? It means that to have all those overdoses, they need to be buying much more drugs, much more, many more drugs, greater quantities of heroin, opiates, benzos, whatever the polydrug use is. They've got to be buying a lot more of that from the local drug dealers. That means that the injecting rooms are government-funded accessories for the drug trade. And you wonder, why is it that deaths go up under harm reduction? Well, it's very clear. What injecting rooms do is they prolong the career, the drug-using career of opiate users and other drugs, because they're polydrug users. It extends their career and gives them more time to die of an overdose. If they had got rehab, no, they wouldn't be dying. But it gives them more time to die. And that is what injecting rooms are doing for Australians. We've got to ask this question, does harm reduction actually care whether people are dying or not? That's a good question to be asking. At the moment, there has been a push for legalising cannabis intoxication while driving for medical cannabis patients. And New South Wales recently said, no, we're not going to go that direction. However, it is likely it will come up at the Drug Summit again. And this is something that we really need to know. 62% of medical cannabis prescriptions within Australia are for chronic pain. There's another 8% or so for pain of other kinds or with different descriptions. Now, given that there are 20 random controlled trials that show that cannabis is no better than a placebo, that's a sugar pill, for getting rid of chronic pain or handling chronic pain, patients with chronic pain will be mixing inevitably opiate use with cannabis use. And that's something which is not good because there is a synergy that multiplies intoxication between both of these substances. And is there any wonder that deaths increase under a harm reduction aegis? People are driving around on the road as medical cannabis patients with opiates and cannabis in the blood, which makes them doubly or multiply dangerous as drivers. They are intoxicated at a far greater level. And so you ask, is legislation, if they want this at the drug summit, is it mindful of the lives of other drivers? Or are they only ever focusing on the cannabis user and their comfort to the detriment of the lives of other people? I think this is a real problem. One of the other things that will definitely come up at the drug summit will be decriminalising all drugs. Now, Portugal did this in 2001. It implemented a new policy which was all about dissuasion, where the goal was to decrease illicit drug use in that country. And so they took money from the policing of drug use and they put that into counselling for drug users and into putting them into methadone programs and so on. And this was all to dissuade them from using drugs. Now, did it work? Interestingly enough, the latest figures that we have are from 2016, which are on this graph here. And we're still waiting for the 2021 figures. Yes, they did a survey back there, but we haven't seen the results. I have seen some reflection that the results for lifetime use have gone through the roof, but we haven't seen this important indicator here, which is use in the last 12 months. And this has gone up since 2001 by 59%. So use has increased. We said before, do Australians want more drug use or less drug use? Well, obviously, if we want less drug use, we don't want to go the decriminalisation track, which increases use. When it comes to high school kids, they shouldn't be using drugs at all, and it's not decriminalised for them in any shape or form. It's always illegal for kids to be using drugs, and yet their drug use has gone up by 80% by 2011. Fortunately, they've been able to get it back to an increase of 24% over 1999 levels, but drug use has gone up, increasing harms and deaths. Now, obviously, when we look at the wastewater data, which is over here on the right, Portugal is figuring across the whole of Europe. There are 27 countries in Europe and all of the, I think it's 104 cities where they do wastewater testing. But Portugal comes up in the top 4 or 5 every time for the use of cocaine, ecstasy, cannabis, or ketamine. And so these figures that have been put out saying, oh, Portugal has, very low drug use is absolutely not true. And it's playing out in the deaths which are happening in Portugal. Here are the overdose deaths, which have gone from 2005 from 9 and have peaked in 2019 at 72. These are very significant increases. And we know that to have all of those opiate deaths, there has to be increases of opiates by roughly the same amount. It goes in a fairly much a similar relationship. If there is an increase of 10 deaths to 72 deaths, then there is going to be a 7 times increase in opiate use. And so this is the problem that Portugal has. Is this what we want for our country? Another thing that may come up, but I think it might be a bridge too far at this drug summit, is cannabis legalisation, the recreational use of cannabis. Now, what happened in Colorado, and this is really instructive, they have very, very good stats in Colorado over in the US. Now, what happened in Colorado was back in 2009, they had medical cannabis before that date, as you can see down the bottom here, And medical cannabis was, they only had 3,000 patients until in 2009, they did a kind of a quasi legalization of cannabis and they made cannabis, medical cannabis, fully available from shop fronts and easily available to get prescriptions. They loosened it all up, and that was the beginning of their legalization period and the sharp increases in all of these indicators that we're going to see. So going up to this one, cannabis use, between 2009 and 2016, there was a doubling of adult cannabis use. Now, I'm actually citing the figures for people over 26 years of age, and this graph is for 12 plus, where the lower age groups moderate that doubling of cannabis use. But cannabis use did double, and that is a very significant thing, particularly because cannabis causes so many cancers, causes so many birth defects, it causes aging. There are so many harms that cannabis has, which have come out in major population studies in the last 3 years. When it comes to hospitalizations that are related to cannabis, the hospitalizations went up 340%. This is major harm that is happening due to this harm reduction measure. Harm reduction, you say? Oh, they say, well, they're getting harmed by the laws against drugs. You know, they've got a criminal record. That's harm. And harm reduction is all for cannabis legalization. So look at the percent of all traffic deaths where the driver tested positive for cannabis. And those have gone up 230%. And for suicides where cannabis is present, they've gone up 410%. Now, this is increases in deaths. Why is it the harm reduction creates more mortality and more harm? There it is, right before you on the screen. By 2016, a whole bunch of states had legalized recreational cannabis use or had it in process at the time. And so the ones that were already legalized are in red. And there are some like Rhode Island, which you'll see here, a blue one that is in between the red bars, where they were working on cannabis legalization and they got it at that election that year. And the same with others that are down amongst these red bars. And you can see that wherever cannabis has been legalized, drug use goes through the roof. And all of these states have suffered from the harms of cannabis use and the deaths that result from them. Now let's go to the solution. And this is what the Drug Summit really needs to be focusing on. What is the solution? How can we be reducing deaths within New South Wales and indeed Australia and stop this bleeding that we're having under harm reduction where it is given priority over drug prevention and rehabilitation? Here are 4 countries in the world that have had really good results. The first of those is Sweden. Now, Sweden, back in the late 60s, had the highest drug use, illicit drug use in the developed world. And they implemented a new policy at that time, which was a restrictive drug policy. And it was all about educating their kids in schools, good drug prevention programming, mandatory rehab, and really compassionate, good policing. And this is what happened. Their drug use was able to plummet, go down markedly. And by 1992, Sweden suffered a recession, economic recession, where they weren't able to spend on their drug policy, and so drug use went up. By 2001, they were able to resume after that recession had finished. They resumed spending, and you can see the drug use of these kids in school is plummeting once again. We go over to Iceland. Now, Iceland was able to reduce its illicit use of alcohol, which is illicit for any high school kid, by 90% over those years that you see on the graph. And cannabis use, which is down lower, ever used cannabis, this line here, they were able to reduce that by 50%. Sorry, that's by 60%. Within Australia, Tough on Drugs was able to reduce drug use for all age groups. This is not just students, but this is for all age groups from 15 to 64 by 40%, roughly 40%. And so that is a great success that you see there, to the extent that the United Nations, UNODC, Office of Drug Control, produced a booklet about how successful it was. And then we come over to the US. Now, how many of you have been told that the approach of the US in preventing drug use, which was called the Just Say No program, how many of you have been told that it was a failure? Well, let's have a look at the actual stats. And this comes from their surveys of high school and uni age, let's say, college age drug users and students back at that time. So there was a 70% decrease in use before 1992. In 1992, George Soros, our good friend who funds the harm reduction movement, started putting money into his drug policies worldwide, which were harm reduction and trying to get drugs legalized. And so, as a result, drug use went up as he poured money into his cause. What we see with college age young people is that there was a 50% decrease for them as well. And so we know that drug prevention and rehab can actually do great things. So what do we need of this drug summit in New South Wales? Well, it is very clear what these graphs show us is that we can be reducing drug use, we can be reducing drug deaths, we can be reducing drug-related harm within the community and to that constellation of people around each drug user by getting people off drugs and getting less drug use in the community in the first place. We've seen in this presentation that harm reduction inevitably increases drug deaths and mortality and harm. It is only doing damage to the community. And what this New South Wales Drug Summit must do, it must prioritise these things that you see on your screen and downplay anything to do with harm reduction and certainly any of the things that we've looked at that they're going to make as part of their harm reduction agenda for this summit. Thanks for listening.